Welcome to International Patient Safety Goal. JCI Preparation of Al-Hada Armed Forces Hospital 2025. International Patient Safety Goals, IPSG, were developed by the Joint Commission International, JCI, to help accredited organizations focus on specific areas that significantly impact patient safety. These goals are designed to improve the quality of care and reduce the risk of harm to patients. IPSG goals are: 1. Identify patients correctly. 2. Improve effective communication. 3. Improve safety of high alert medication. 4. Ensure correct site, correct procedure, and correct patient surgery. 5. Reduce the risk of healthcare-associated infections. IPSG 1. Patients are identified before providing treatments, before performing procedures, before any diagnostic procedure, and before any other treatments, cares, or interventions intended for a specific patient. Examples: prior to blood samples and pathology samples, prior to forecannulation, medication administration, on admission, transfer of patient, and prior to MRI, X-ray, and CT scan. How to identify patients correctly? Use two identifiers: patient MRN number, patient's full name. Must never use patient's room or location to identify patient. Patient and family should be involved in the process of identification. In the event of same name in same ward, birthday will be used as third identifier. IPSG 1. Identify patients correctly in comatose or disoriented patients such as unconscious, mentally unstable, infant, incapacitated, under anesthesia and with no identification. The parent's carer spouse must confirm that the details on the patient identification band are correct prior to attaching the band to the patient. In the event that the patient is unable to participate in the identification process, unconscious, mentally unstable, infant, incapacitated, under anesthesia, and the absence of parent carer, the identification should be carried out by two hospital staff using identification information available in the medical records and confirming its equivalence with the patient's wristband. For unknown identity or unconscious patients brought in the emergency department, e.g. trauma, identification can be made by member of the resuscitation team or ED staff. Identity band must state XXX1, XXX2, and the temporary MRN number. If the identification band cannot be attached to the patient's wrist or ankle, the band must be securely attached to visible part of the patient's body. Reason for not securing the band per usual practice must be documented in the patient's medical and or nursing notes. All newborns must be identified by the primary registered midwife and registered nurse who are attending the delivery using ID band and footprint. Immediately after delivery, 3 identification bands, tri-band, on to be placed on newborn's wrist and ankle and 1 for the mother. ID band shall be coded with all of the following information: A. Baby's MRN. B. Start with baby followed by gender. Then by first, middle and last mother name. C. Date of birth. D. A mother's MRN. In case of multiple pregnancy, following should be added: twin 1, twin 2. Triplet 1, triplet 2, triplet 3. IPSG 2. Effective communication, which is timely, accurate, complete, unambiguous, and understood by the recipient, reduces errors and results in improved patient safety. Breakdowns in communication can occur during any handover of patient care and can result in adverse events. IPSG 2.0 Critical Result. IPSG 2.1 Handover Communication. Critical result. Variance from normal range that represent pathophysiologic state that is high risk or life-threatening is considered urgent or emergent in nature, and in which immediate medical action is likely necessary to preserve life or prevent a catastrophic occurrence. The reporter will communicate the critical result and shall identify himself, the reason for call, the patient and test result. Reporter will provide the report to the receiver. Receiver will document, and write, the critical results. Receiver will read back the information provided. Reporter will verify the information is correct. Both the reporter and the receiver must document the readback verification procedure was carried out. Receiver will inform the most responsible physician on-call physician within 15 minutes. Documenting actions taken in response to critical result in the patient file shall not exceed 30 minutes from time result are received. Here is the updated critical result form. To complete the necessary information to ensure accurate recording and timely informing of most responsible physician or on-call physicians. Critical result from point-of-care testing in the unit. From glucometer reading, newborn blood glucose below 40 mg dl and 300 mg per dl are considered critical, while in adult less than 50 mg dl and greater than 396 mg per dl. These needs prompt action. Reminder: all positive culture from blood culture are considered critical results. Handover. Transfer of responsibility for a patient and patient care. Referred to as hand-off communication or handover. It occurs between healthcare practitioners at change of shift, between different level of care in the same hospital, from inpatient to diagnostic or treatment departments, and between staff and patients' families at discharge. For transfer of emergency cases to operating room and between labor and delivery, need to use request for emergency procedure case form. For transferring patient between department or services, nurses need within hospital patient transfer checklist. Nurse handover between shifts, nurses need ISBAR form for units wards. Between labor and delivery and nursery and NICU need to use handover of the newborn. From nursing units to procedural area, OR, endoscopy, cath lab, bore holding area nurse to operating room nurse need to use pre-operative checklist. Recovery room nurse to primary nurse of the unit need ISBAR. Nurse to recovery room nurse or to intensive care unit need surgical record. For discharge, patients needs to use final discharge summary and at the same time to include the home instructions. Point 0. Improve the safety of high alert medication. What is high alert medications? Drugs that bear a high risk of causing significant patient harm when they are used in error. Examples are narcotic medications, insulins, and chemotherapy drugs. Strategies to mitigate the risk are stored in bin and labeled with auxiliary label high alert medications, independent double checked. And verify 10 rights of medication administration. List of high alert medications are updated annually by pharmacy department. Here are the latest list. Improve the safety of look-alike sounds-alike medications. Look-alike sounds-alike medications. Medications that have similar product packaging or that have names that sound similar can easily be confused by healthcare practitioners and may lead to potentially harmful medication errors. Strategies to mitigate the risk are stored in bin and labeled with auxiliary label with green label of look-alike sounds-alike, using of tall man lettering, prescribed with both generic and brand name and indicate the indication for use. Verify 10 rights of medication administration and check indication on the prescription prior to administering. Here are the list of LASA. Annually updated by pharmacy. Be familiar with this medications and its indication to avoid confusion. Manage the safe use of concentrated electrolytes. Concentrated electrolytes are vials of concentrated forms of electrolytes that require dilution or other preparation before preparation to ensure patient safety. Considered also as high alert medication. Strategies to mitigate the risk are only qualified and trained individual have access, shall be segregated from other medications, standardized auxiliary label colored orange with. Dilute before administration, verify 10 rights of medication administration, independent double-checked, use of infusion pump and standard protocol for replacement therapy. Here is the list of concentrated electrolytes made by pharmacy department which are updated annually. Hospital implements a process for the preoperative verification and surgical invasive procedure site markings. Surgical site marking. Preoperative verification process. Timeout. Surgical site marking. Performed by the doctor performing surgery or procedure and must involve the patient. Marking must be visible and surgical site marking pen should be used so as to remain visible following skin preparation and draping. The site of surgery shall be marked with an arrow. All cases involving laterality, multiple structures or levels must be clearly marked. Exception midline structures, single organ, caesarean section, cardiac surgery, gallbladder, liver, emergency, signs of trauma wherein injury to the planned procedure, neonates, premature infants, frail elderly, interventional cases insertion site is not predetermined. For neonates, premature infants, frail elderly, an easily removable soft sticky adhesive tape with a marked arrow shall be applied. Alternative, identifying the surgical site, a human diagram with an arrow shall be indicated. Most responsible physician should explain to patient the risk for refusing this procedure. Document on patient's file should be done both by most responsible physician and nurses. Preoperative verification is an ongoing process of information gathering and confirmation. The purpose of this is to verify the correct patient, procedure and site, ensure all relevant document, images, and studies are available, properly labeled and displayed, verify that any required blood products, special equipment and implants are present, whether there is a risk of blood loss, any known allergies and whether patient has a difficult airway or aspiration risk. Timeout is held immediately before the start of the procedure with all team members are present. During timeout, the team agrees correct patient, correct procedure to be done and correct surgical invasive procedure site. Sign out. Conducted in the area where the procedure was performed before patient leaves. During sign out, name of the surgical and invasive procedure that was recorded. Completion of instruments, sponge and needle counts. Labeling of specimens. Any equipment problems to be addressed. What went well, and any problems noted, with follow-up interventions through quality improvement activities as necessary. Non-operating room procedures like lumbar puncture, thoracentesis, chest tube insertion, incision and drainage, CT-guided aspiration and biopsy, and dental surgery need safety checklist or timeout form.
IPSG 5. Reduce the risk of healthcare-associated infections. Proper hand hygiene is central to the elimination of hospital-associated infections. This includes efforts to standardized hand hygiene compliance data collection and ensure that the data are valid. Hand hygiene guidelines should be posted in appropriate areas, and staff should be educated in proper hand washing and hand disinfecting procedures are required. Hand rub is cleaning of hands by rubbing them with alcohol-based hand sanitizers, and takes 20 to 30 seconds. Meanwhile, hand washing is cleaning of hands using soap and water for 40 to 60 seconds. Hand washing should be done instead of hand rub when hands are visibly soiled, Clostridium difficile patients, and after using powdered gloves.
IPSG goals are: 1. Identify patients correctly. 2. Improve effective communication. 3. Improve safety of high alert medication. 4. Ensure correct site, correct procedure, and correct patient surgery. 5. Reduce the risk of healthcare associated infections. IP